Uh, Good afternoon or good evening, wherever you are. My name is Abdurrahman Nimeri. I'm the chairman of the Ifso Communication Committee, and it is my pleasure and privilege to host the 11th Ifso Journal Club in its new format as a webinar. Today we have with us Dr. Luciano Antosi, who is an Argentinian surgeon working currently in Spain in the unit of Miguel Carbajo. And he's going to talk to us about the recent publication looking at anastomosis bypass adolescents, looking at their 5-year results that was published in obesity surgery. So few housekeeping issues before we start. You can actually look at the full text of the article on our Facebook group if you like, and you can post questions and we'll go through them after the presentation, which will be the first 20 minutes. So without further ado, I would like to invite Dr. Luciano Antosi to start his presentation.
Okay, good afternoon. Thank you, Dr. Nimeri. Each one of the participants connected to the webinar, and of course, Ifso authorities for the opportunity to share this paper. In what I believe, it's a great space to optimize data sharing. We will review this interesting topic. It is a 5-year follow-up in children and adolescents undergoing OHB. This is Dr. Carbajo's experience, but I will be taking his place today. This is the visual abstract that has been used to catch your attention. I can see 21 assistants now. You can start by saying something that everyone knows, and that is that obesity is a result of a complex system with many subgroups, like the spiderweb shows. I'm not going to get into that, in which environment, lack of education on eating habits, genetics, energy expenditure, and in the case of minors, construction of identity and cognitive maturity are also present. And what is the result? The result is that 20% of children in Spain are obese. The numbers around the globe probably are quite the same. And the consequences are well known. We can find arthropathies, sleep apnea. This is all about children. 20% of severely obese children have sleep apnea. Anemia rises twofold when compared to lean children, and about central obesity, insulin resistance, dyslipidemia, hypertension, glucose intolerance, and we can call it the metabolic syndrome. That's a definition that we can't use yet because it's ill-defined in pediatrics. So attention should be paid regarding psychological or social consequences. If we are getting a hard time to explain doctors and adults that obesity is a disease, imagine that in kids. Bullying is frequent, absolutely, everybody knows that. A third of the children are depressed, they have low self-esteem, 1/4 have anxiety. And also, the start point that we see in the consult is that there are common nutritional deficiencies in obese patients. This is Mary Freluc that took the great show to gather information on nutritional deficiencies in obese children and adolescents. And this is the results. Vitamin A, E, and folates have a negative correlation with BMI. Vitamin D has been found deficient in 27% of patients and severely deficient in 15%. Iron also is bad. Zinc, again, negative correlation with BMI, and selenium increases with deficiency increases with BMI. So about maturity findings in obese adolescents, there are early maturity in obese boys. There isn't early maturity in obese boys, but it's clear in obese girls, and they having gynecological problems. The most common ones are early onset of puberty, reduced fertility, 2 times irregular menstruations compared to lean, dysmenorrhea, and altered sexual behavior. These are some others: polycystic ovary syndrome, macromastia, risk on breast, and endometrial cancer, but that goes later in life when they become obese adults. About obstetrics, there are findings of preeclampsia, labor induction, preterm birth, large infants and neonatal complications in the obese population. I won't go into details with that. So based on this data, and with the York study stating that 80% of obese children become obese adults, it is of no surprise that one feels the necessity to do something. And with the safety and efficacy of surgery for obesity and the increasing experience of multidisciplinary teams, a retrospective review has been done by Dr. Carvajo's experience. This is the title, you already know it. It's available for you to read it. Initial experience comes from year 2004, when there were scarce recommendations, but now we have an Ifso position statements with level 2 of evidence and recommendation grade B that resumes the 2012 ASMBS selection criteria that establishes that all adolescents, boys and most adolescent girls, 18 years old with a BMI of 35 are greater than the 99th percentile. So the threshold used for adult selection criteria could be appropriate for children with 35 of BMI and major comorbidities, or 40 with other comorbidities. Of course, it has to be considered that patients should nearly attain adult stature with previous weight loss attempts. This is common. They have to demonstrate commitment in psychological evaluation and agree to avoid pregnancy for at least 18 months. That sometimes doesn't happen. They need to have decisional capacity and be adherent to nutritional guidelines. This is important. Parents are part of the decision, but in red, I show this, that sometimes parents are making some coercion on children that don't want to be operated. So this has to be screened and noticed. Kids sometimes go there because parents take them and they don't want to. Most of them want to do something, but some others don't want to. So these are the goals when bariatric surgery is proposed. Of course, achieve sustained weight loss, minimize the risk of adulthood morbid obesity, improve comorbidities or psychological profile. The team members are the same as any other team, but the pediatrician comes into part, mostly because patients have to be evaluated by Tanner score, and Tanner score is not so easy to show Tanner score to someone you don't know, like a surgeon or someone that you are not confident with, and kids are confident with their pediatrician, so mostly because of that. And about stature, that this is very important. Mostly children from 15 to 18 have achieved like 99% of their adult stature. So you will see our charts later what the group was. And Tanner staging was only performed by a pediatrician in patients under 16, but no in the other group. So what are the options? There's a lot of publication about this. Adjusted gastric band is not usually performed because there are patients that do very well, but 25% reparation rates were found due to complications or weight regain. And weight regain takes another bariatric surgery with its own complications. So I think it's declining. It was a good option in the past, but I think it's declining. The other three techniques require supplementation, like OHGV. Sleeve gastrectomy is being questioned about weight regain and GERD. I can't really make a statement about this topic because there's still controversy. You find half people saying one thing and the other half saying another thing, but it's a concern. In Roux-en-Y gastric bypass, weight regain in adults, it's common, but when I reviewed the papers in children, it wasn't so frequent in adolescents. But anyway, children are gonna become adults sometime and maybe weight regain appears. And what was difficult about this, that the AMOS study that 81 adolescents for 5 years prospectively attained had a 25 reoperation rate. 11% was due to cholecystectomies, but 14% was due to small bowel obstruction. That was a concern. And BPD in adolescents has been published, but they have the same weak points that when done in adults. So the 2011, hearing myself. So the 2011 IDS statement showed that there was a significant two crosses there or high risk of deficiency in most of the surgeries performed in adolescents, and most of them require supplementation. So OHEB was proposed as an effective, durable, and mostly reversible technique if you want to. This is our numbers. We are just getting into the paper. These patients are private practice with similar ethnic, social, cultural, and economic characteristics. This is a select group. It only represents 1.11% of Dr. Carvajo's total surgeries. Mostly female with a mean age of 17.8 and a BMI of 44.2 with a standard deviation of 5.9. So BMI, can you see the video? That's a small video. Is it working? Okay, BMI is important because when we use the usual charts for children, like shown here, you input the data. And this is a patient, 19 years old with 113 kilograms, and her BMI was 39.1, but you can't really see where she is in the chart. Like you see, there's nothing in the chart. So this is because when percentiles go around 95%, they lose specificity. So we have this special chart. These are our patients. As you can see, most of the patients are within the 16 to 18 years old. Very high BMIs, far beyond the 35 recommended for ASMBS. And you can see here that there are 3 or 4 patients that we have to pay special attention. That's showing. Okay, I have a problem with the. Okay, there were 3 or 4 patients that I wanted to show that are marked in the charts, but the thing is that they were very young, but very severely ill. They had dyslipidemia, hypertension, insulin resistance. I wanted to show all of them to you one by one, but it's not going to work. It takes a lot of time with the animations. Sorry about that. This is the last patient, the 13-year-old one that had liver steatosis, insulin resistance, and hypertension. And this is the severely ill one. He's 57.5 of BMI. The percentile was 219. He had diabetes, dyslipidemia, sleep apnea, and liver steatosis too. So our preoperative evaluation included all of this: complete blood count, liver function test, lipid profile, thyroid function. It doesn't differ much from the adults, but in some patients, Turner score because of age under 14 and skeletal maturity was evaluated too. About liver steatosis, we didn't do biopsies, of course. It can be done. It's a separate paper, but this it adds some more risk. So liver steatosis was evaluated by ultrasonography and parameters on the biochemistry only. And these are the results. In the preoperative findings, there is a mistake here. The patient that referred with GERD in verbal scores were 4. That represents 20. That doesn't represent 23% as shown in the paper. It's 10%. But we found 8% diabetes, 10% hypertension, 23% dyslipemia, 30% arthropathies. Sleep apnea was very common, as shown in many other papers, and liver stenosis too. It's a little under what has been published. So this is the surgical technique. We will go step by step for those of you who don't know it. It consists of a long pouch, 60% biliopancreatic limb, a 40% common limb, and a fixation of the biliopancreatic limb to the gastric pouch. Large anastomosis. It says 2.5, but we use 30 millimeters endo-GI to do the anastomosis. And it has to, and the pouch has to be very long, and total bowel length is very important. This is what differentiates this technique from Rutledge technique. The other day we were talking about adding a port. If you can see my arrow, this is very important. This port is very important. Usually you can do the surgery with this, but this one here for bowel measurement is very, very important. So at first, the patient goes in reverse Trendelenburg, and you can see the surgeon here. This is right hand that goes to the port I was telling you about. The second assistant or the cameraman goes there, and the third assistant in between the legs. And this is total bowel measurement. In the initial experience, you do it. In the initial experience, you just measure with some tape, or you have to get used to this. But then once you have learned this, you know what your 10 centimeters are. These are 10 centimeters. As you can see, the right hand is very comfortable. The camera is comfortable. This is the jejunum. Then to go to the ilium, you have to go further down, but you can be counted. This one shouldn't rush with this maneuver. There's no way to rush, and there's no meaning for that. And once this is complete, we put the patient in reverse Trendelenburg. The surgeon goes between the legs, and the third assistant goes to the patient's left. And this is the long pouch I was talking about. This is a long pouch. I mean, you can see the end of stitch there. This is the 20 centimeters mark. And I can show you here. This is the stomach, and you can see the stomach goes back there. So this surpasses the stomach, and the anastomosis is back there. This biliopancreatic limb is fixated from this spot all the way down, and the anastomosis is right there. So this is another paper. What were our findings about Carvajo's experience on total bowel measurement? Technical aspects are important. For example, major findings of this paper were that there is not a linear relationship between weight, BMI, and total small bowel length. Dr. Taquino found a relationship with height. We didn't find that. And we found that the ratio between common limb and total bowel length has more power prediction results than common limb length alone and biliopancreatic limb length alone. And the recommended one is around 45%, 55%, 40 to 60 if you are very aggressive. So, but you shouldn't go below 190, 180. And as you can see, in the Spanish population, that represents almost 3% of the patients. So if you don't measure total bowel length, you can have problems with some patients, and you won't know why, and that really happens. This is the final result when one does an X-ray. You can see it looks pretty much like a regular Roux-en-Y gastric bypass. Somewhere around here would be the biliopancreatic limb that went up and then goes down. But this is the usual control. And more important than surgery is follow-up. I mean, surgery is just a couple hours. We won't do much more than 2 hours with this, but follow-up is for life. And Dr. Carvajo has a way to treat these patients that is very concise, very special. He gives them everything everything for the follow-up. This first part are recommendations that I think everybody does this. The indications for immediate postoperative follow-up, but he also does controls in 3, 6, 9, 12, 18 months, and 24 months, and then yearly, because the 2 first years are important. I mean, this is a powerful operation. You can't just operate the patient, see him a couple times, and then forget about it. You have to control them very strictly the first year. He uses PPI for 6 months and sucralfate for 1 month. Of course, in the early period, protein shakes and supplements with maximum and vitamin A are daily, lifelong. Calcium citrate is daily. Vitamin D is weekly. Intramuscular vitamin B12 every 3 months. And these recommendations are done to patients. Avoid pills, lifelong. Try to use powders. Avoid fats, lifelong, because you can have steatorrhea or diarrhea. Avoid sweets, refined foods, and drink.
Can you hear me? Your voice went away, Dr. Antosi.
Excuse me? Can you hear me well?
We can no longer hear.
Oh my God. Hello, hello, can you hear me now? Hello?
No, we have lost your voice for some reason.
Let me see microphone here. Let me disconnect the.
I know, we cannot hear you.
Wait. Can you hear me now? Hello? Can you hear me now?
Yes, Luciano, we can hear you. Please go on.
Can you speak now? I cannot hear you.
How far did we get? Did you see the post-operative indications and follow-up? Ah, yes. I think we were here. Did you hear this part? Hello?
Yes, please, Luciano, go on. We can hear you now.
We cannot hear you.
Dr. Nimeri, Manuela is telling me that she can hear me.
Can you see your microphone is muted?
No, but Manuela can hear me. I think that
either I don't know how to on your laptop or on the app, because like the voice went away and we can't hear you.
Manuela can hear me fine. I don't know the rest of the assistants.
Yes, I can hear you.
So do you want me to end the session, Manuela, and start again, or?
No, I think we can go on. I think probably it's just one computer that has the problem. So I guess you can just go on.
Hello?
So I'm sure you can hear me, but for some reason I cannot hear you, and I suspect the audience also cannot hear you if I cannot.
Okay, so
what I suggest, maybe you can log off and then log on again.
Okay, sure.
And while
sure.
So while he logs on again, for the people in the audience, you can actually in the handouts is the article. You can look at it. One of the reasons we felt that this article is interesting is because in adolescents there's really no clear procedure that's recommended for most patients, and there is literature in the past of using open BPD by Dr. Scopenaro for adolescents, and at 2 years it showed that the mortality was high, the nutritional deficiencies were high, and it was recommended not to be done.
Hello?
And recently, surgeons have been using sleeve gastrectomy. Surely the LAPS consortium. So you're back. Can you speak, Dr. Santosi?
Yes, I'm back. Can you hear me? Can you hear me now?
Yes, I can.
I didn't touch anything, so it should be working.
So I, for some reason, cannot hear you. I want to check with someone else, see if someone else can hear you.
Okay.
If anyone in the audience can just write in the question box.
Let me. I think the problem is your computer.
Actually, have not done anything. Just the voice went away. Can someone write in the box if you guys can hear Dr. Luciano? So if you can hear him, he can continue presenting, and I will log off and then log on again. Okay. Let me see here. Okay, so apparently they can hear you. So why don't you continue? I will log off and log on again. But for some reason I cannot hear you. I'll log off, then I'll log on again.
Okay.
You can continue, please.
Okay, I'm gonna continue. Manuela, do you think I can continue, or is it going down?
Yes, please go on, Luciano. Thank you.
Okay. So postoperative indications, we were in the middle of this. These are all important indications. Switch, refined food, drinking liquids immediately after a meal, that's not suggested. And patients here in Spain do mainly 2 courses. It is suggested that they do the proteins as main course, so they have more space for eating proteins. Every patient gets this kit, I can say that. It is very important that this kit has a special formula. As you can see, for those of you that don't speak Spanish, it says multivitamins and minerals for surgery like BPD or duodenal switch. So this goes once a day, and these are the composition of the multivitamin, and that goes with some more vitamin A also. Follow-up requirements for patients: 3, 6, 12, 18, and 24 months are seen in those envelopes there. The patients get there with all they have to do, all the analytics specified, like you see. They have to do biochemistry, and they have to complete some questionnaires, and just send them back to the doctor. At least that's the least patients should do. Ideally, they should come to control, but we know every bariatric surgeon know that patients are sometimes are not that responsible. And going to the results of the paper, remission of comorbidities like diabetes defined as glucose below 110 and AV1C below 6.5. Dyslipidemia defined as triglycerides under 200 and total cholesterol under 200, and blood pressure below 135/85. All without medication were considered success, and this happened in the patients. Remember, this is a small number that can have like a small impact because it was a small number. But anyway, the patients had their remission on comorbidities. About total cholesterol and triglycerides, these were the charts when the patients were losing weight. the controls, and glycated hemoglobin also going normal. This is the weight. Weight came down for a BMI 42 to a mean BMI of 26 at 5 years. And total proteins and albumin were controlled in all patients. It is important to know that in the third and fourth year, many patients lost to follow-up, and they were called for the fifth year follow-up because they don't come, and we saw some deficiencies there. About complications, we had one chronic anemia in a patient lost to follow-up. She had a familiar problem, and she lost to follow-up. She had surgery in 2008. She was 18 years old when she was operated, but when she came back, she had severe anemia that required almost a year of iron supplementation to go back to normal levels. There is one patient that is being evaluated now for surgery. He was BMI 43 when he was operated. That was in 2004. He was 16 years old, and Dr. Carvalho by that time was not used to measure the entire bowel length, and now he's BMI 36, so maybe he will get a new surgery. 3 patients have been performed for cystectomies, and there was one ventral hernia that was not treated. This is not from the patient from the paper presented now, but it's also Dr. Carvalho's experience in 1,200 obese patients. And you can see numbers. Maybe numbers here are more real because that's a large cohort. It's different from getting 39 patients. And you can see that there was 1.1% of protein malnutrition, 2% of GERD, 1.25 severe iron deficiency anemia. Some patients had nausea and vomiting, and hair loss, diarrhea, and fecal odor was variable because it depends mainly on what the patient eats. And these results showed that what I was saying earlier, that in the first period of surgery, patients get deficiencies, but they will do better with time if they adapt to supplementation and to the new diet. About GERD, this is a very important subject these days because everybody is talking about it. This is an ongoing paper that we are starting right now. We are doing a multicentric control, endoscopic control with this chart, looking for bile in the esophagus, if there's a hiatal hernia, esophagitis or not, if there's Barrett's, bile in the gastric pouch, and we divided the stomach in thirds and to see what happened if there's gastritis or not. And regarding follow-up, finally, I wanted to say this. Lauren Bailey from France showed that in 300 patients operated, almost 18% had anemia in the first period, but this red line here shows that there was a special intervention of new guidelines to treat these patients and to modify follow-up, to insist on follow-up, and you can see how anemia went down with time. So to conclude, I wanted to say this, that one anastomosis gastric bypass is a valid surgical option for long-term weight loss and comorbidities remission in childhood and adolescent population. Malnutrition and vitamin mineral deficiencies can be controlled with specific supplementation without affecting normal growth. We didn't see any alters in growth in this group of patients. But adherence to lifestyle changes and follow-up is of extreme importance. Maybe total bowel length measurement is essential to perform a safe technique and to achieve adequate long-term results. Thank you very much.
Thank you, Dr. Antosi, for your presentation. And my apologies for the mishap with the voice at the middle of the presentation. So I have a couple from the audience, and I also have some questions. Let me start first with the questions from the audience.
Okay, sure.
Sure. So Let me see here. I think there are many comments of people telling us that they can hear, which is great. So maybe while I'm putting the questions from the audience, I want to ask you questions about the way you do the procedure, or Dr. Carbajo's group, which is you measure the entire bowel, and then you make sure that the pancreatic limb is 60% of the bowel bypassed, which is completely different than the way one anastomosis gastric bypass is described. This is kind of similar to what a SADI procedure would be, very, very close to what a SADI is. So my first question is, recently the Omega multi-center randomized control trial from France showed that when you use 200 centimeters only, which seems to be much less than the measurements you do in your patients, the risk of nutritional deficiencies, the risk of anemia is much higher in one anastomosis gastric bypass to root gastric bypass. How can you explain that even though you are making more biliopancreatic limb, you're making more measurements, your rates are lower with anemia and nutritional deficiencies? Can you explain the reason?
Yes, it has to be understood that anemia and nutritional deficiencies exist. No one wants to say something that is not true. They totally exist. But about biliopancreatic limb itself, this paper that we're going to publish in obesity surgery is very important because it says that there's a group of patients that using 200 centimeters biliopancreatic limb will have a short small bowel under 180, and that was our cutoff point. I think this can be very different. I was watching at the chart with Miguel's experience the other day, and we compared with our own experience in Argentina, and we find different limb lengths also. I don't know if it's a matter of geography or eating behavior or what, but it's totally important to know that there's a high variable length in these patients. So if you get the 60-40 or the 55-45 chart, you are almost certain that no patient will get less than 190 centimeters limb length. And the other thing is that limb length measurement is not standardized. Sometimes 10 centimeters for one is 10 centimeters for others. So that's why I showed that video that showed what 10 centimeters were for Dr. Carbajo. He's been doing the measurement with tape for a lot of time, and now he doesn't do it like that anymore because he has the eye, as you can see. But watch out with that. I think it's not so specific. Maybe the percentages radio can be accurate because the same surgeon on the same day can measure without mistake. If we go from 1 to 100, I mean, it's easier to notice if you're making a mistake or not. So the centimeters are going to be a problem. About BPD, about SADIS also adds some restriction with the sleep and with the presence of the pylorus. So I don't know if they are going to get the same numbers, but in the last Congress in Argentina, that was the chapter, Dr. Carbajo and Dr. Torres were in the same table discussing this, and with Miguel charts recommending the 60-40, it totally was coincident with what Antonio Torres was recommending for his patients. So we're trying to get the state of the art of the technique, and we will need more time, but I think this recommendation is based on experience and a lot of patients, and it can be achieved.
So there is another question from Dr. Harris asking, how is the sample calculated? Is this a consecutive sample? And I will add, what's your % follow-up?
The consecutive sample, I didn't understand that. Excuse me.
Meaning
the follow-up. All the patients were controlled the first year. We had a lot of follow-up in the 3rd and 4th year, but for the paper, we took the measurement on the 5-year group. So all the patients shown here have the 5-year follow-up. So that's what I can say about that.
Okay, so there is and then this 39 patients includes patients or includes a selection of some patients? The 39 patients include in the stay period?
Okay, no, so Dr. Carvalho performs OHB mainly. He doesn't do any other techniques. There's a selection of patients when they come to visit. If they don't fulfill the ASMBS guides as proposed like almost 10 years ago, but not about the technique. Maybe the technique can be tailored when the patient is operated regarding the bowel length.
Sure. So there's a question from Dr. Surendra Ogali from India. He's asking, were Peterson space closed, and what was the internal hernia rate in this series at 5 years?
Yes, that's a good question. We were talking about that the other day with the teaser. The Peterson space, it's cyst. I mean, there's you get bowel up there to the pouch, and of course there's a space behind the bowel. The main difference is that bowel is uncut and mesentery is uncut. So somehow Peterson complications are not seen. What Dr. Carvalho used to do in his initial experience was to fixate the biliopancreatic limb with stitches to the stomach, to the remnant stomach. And now what he's doing is from the anastomosis all the way down, he's using glue. This is a technical detail. We didn't compare this to do nothing, but he's not seeing many Peterson space defects. In the 1,200 patients, I think there's none reported also.
Sure. So just as a in general, I think there are now case reports of Peterson space hernia in anastomosis gastric bypass. It's common as Roux-en-Y anticolic because there's one space compared to two spaces, but there are reports of internal hernia after one anastomosis gastric bypass. The next question, I don't know who's the person asking the question. They didn't write. The question is, if someone, let's say, has 100 centimeters of small bowel, when you do 60-40, you are bypassing close to 360 or 400 centimeters of bowel, and this is like a gastroileal anastomosis. So his question is, how can patients not develop malnutrition? And I will add, what was the mean length of the common channel in the 39 patients?
Yes, I didn't hear the example of the bowel length, but it's okay. I can answer that anyway. Yes, many times you're gonna get gastroileal bypass with these percentages. I mean, you can even see it. It's mostly gastroileal bypass because if you get to differentiate the jejunum from the ileum about the wall thickness and vascularization and all that, you usually see that you're almost in the ileum every single time. There are deficiencies, of course, but we need follow-up. Everybody needs follow-up. Many of the deficiencies shown or known are commonly eradicated with medication. That's why patients have to be adherent with that, and that's I think like 80% of the time for the teamwork. So about protein deficiencies, diet here has a lot of protein. Also in Argentina, we have seen protein deficiencies in Argentina, diarrheas and increased stools can be managed with Creon and shakes. But see, yes, if you do this kind of operation, you will find these patients. The thing is that you don't reach the point, and you don't want to reach the point where patients don't respond to your therapeutics. So the main difference regarding viral reflux and malnutrition is that mostly patients respond to that. I don't know how many publications there have been regarding conversion of the surgery.
Sure. So the person who has this question is also from India. And that's why I drive this point and make sure I am clear. So if a patient has 600 centimeters small, which is very common, then their common channel is 240 centimeters. So this is actually shorter bowel than Saadi with a smaller stomach.
Yes, but with no restriction.
Correct?
Yes, but with no restriction. I mean, in the gastric pouch and the big anastomosis with no pylorus, in the OHEV, there's no restriction practically. I mean, you have a small pouch, but you could see in the picture of the barium swallow that it goes all the way down to the ileum just in one swallow. So maybe that's different from Sadie. Sadie has the pylorus and they have more restriction, besides using a 60 French bougie.
Would it be fair to call this one anastomosis gastric bypass? It probably is more fair to call this one anastomosis gastroileostomy. Would you agree with that? Or gastroiliac anastomosis, because you're anastomosing the bowel not close to the ligament of Treitz like most one anastomosis gastric bypass surgeons, but you anastomose it very distal towards the ileum. So we understand that the weight loss results are going to be excellent, but the concern for nutritional deficiency, because in all the looped procedures where the anastomosis is towards the ileum, the incidence of nutritional deficiency is higher than what you have shown in your series.
If you're talking about the BPDDS, yes, the malnutrition rates are seen were higher. About this, I don't know if there is a straight line to say this is jejunum, this is ileum. What we have seen is that intestinal adaptation is huge when you reoperate patients. Now there are some papers with the rats, but the important are the clinical ones. You can see ileums or small bowel very large, very hypertrophied. So it could be called gastroileal. I don't know if it would change much because as described by Carvajo with these percentages, he's looking for the perfect surgery when you balance weight loss and malnutrition.
Sure. There's a question from Priscilla Antosi, and she says that adolescents are difficult patients, and sometimes their decision about a lifelong procedure cannot be achieved by themselves. So, the decision. So the question is, did everybody have psychological preparation, and if yes, for how long?
Yes, the psychological preparation was for children and parents. I mean, parents are in this kind of population are more important than children themselves because they have to be with sometimes immature kids, so they have to respond to. The follow-up later, there are quality of life questionnaires with children and psychological problems questionnaires, and the result is great. I mean, children that were bullied and that were depressed had an impact on their social life very high. So it's important the psychological part too. And as I shown on the first part, these patients are very affected on these items.
Sure. So there was another comment also about the importance of psychological from Dr. Zahra, also about pre-op and post-op. So Dr. Stern is asking you, have you had to reverse or revise patient because of malnutrition?
For malnutrition in this group of patients, no. Thank God, no. I mean, this group of patients, about weight gain, we had one weight regain, but no reversals for malnutrition. The main thing is this, there has to be a standardized guideline to say, I'm going to convert this patient, I'm going to do this with this patient, about malnutrition and about GERD. When we read papers and we say, I don't know, it's 10% rate of conversion from one surgery to the other, there should be a guideline. Maybe it's hard to standardize about treatment of the patient and what is the point that you have to reach to say, okay, I'm going to convert this patient, because conversion surgery has its own complications, so we don't want to do that. And conversion to Roux-en-Y also has its own complications, so it has to be very clear about that.
Sure. There's another question from Priscilla Antosi. She says, when an anastomosis gastric bypass can have asymptomatic bile reflux, would routine post-op endoscopy help in identifying asymptomatic biliary reflux, which may not result in intestinal metaplasia in the long term, especially considering that this is an adolescent, may result actually, may or may not result, she says.
Yes, you know, bile reflux, any kind of reflux, you can trust the symptoms. On this patient, it was mainly questionnaire, but any symptom is detected, the patient must have an endoscopy for the 5-year follow-up. And regarding the 5-year follow-up, although you try to encourage every patient to have an endoscopy at the 5th year, only 20% of patients do it. That's really a really hard indication. So sure. I think the problem will be in the long term. If we are suspecting any risk of cancer, that will be in the very long term, 25 to 30 years later. We don't know what can happen with that, as we didn't know what would happen with any surgery 20 to 25 years later. But the thing is that we are not seeing that much reflux or any reflux to say, okay, we have to stop now. It's not that one is doing a surgery with patients with reflux everywhere and say, okay, I continue doing this. No, that's not the idea. I mean, in our center, we do Roux-en-Y gastric bypass, we do sleeves, we do OHB, and it's not that we say, okay, let's stop doing OHB because we have a lot of reflux. Our center, our group was mainly concerned about malnutrition, as you said. That was more a concern than reflux.
Sure. So Dr. Hazem Nassif had a question about the percent of patients who had answered it. So one final question for me. I noticed in the sample of patients, there were some patients with BMI of 39, some patients with BMI 40s, and some patients who are diabetic. How do you choose which patients or adolescents to offer which procedure? How do you counsel patients to have either Roux or sleeve gastrectomy or one anastomosis?
Yes, sleeve gastrectomy is being offered. I would be concerned also about GERD in those patients. But what I was trying to show with the charts is that the BMI is used because most patients over 35 or BMI are severely obese because they are over the 99th percentile, but that kind of looks trend. So you have another chart that goes about over the 99% percentile, sorry. And in the charts, they are going from 120% to 219%. So when you include age in that chart, it's easier to have data and follow up. And about patient selection, as I said, Dr. Carvalho does this technique and he tailors only the small bowel.
Sure. So which do you offer one anastomosis gastric bypass to all comers or specific patients in adolescents?
Dr. Carvalho? Yes, yes, he uses one anastomosis gastric bypass. Yes. He doesn't
for most
sleep.
patients.
I mean, yes, he's more concerned about sustained weight loss and comorbidities weight loss. That I think one anastomosis gastric bypass is showing great results there than the other kind of complications, because he believes that the complications on this surgery can be medically managed mostly. So that's his decision.
Sure. So I will quickly summarize what we discussed and then allow you to give some final comments. In adolescents at 5 years, using a configuration of 60% biliopancreatic limb, one anastomosis configuration with a long gap approach. You've had excellent weight loss results. You've done 20% of patients endoscopy and very low incidence of reflux. You did not have any patients with nutritional deficiencies, and your group does not close Peterson space. So I want to thank you for presenting the journal club for us, and I want to ask you if you have any final comments or remarks to us before we continue.
Yes, the remarks. Nobody should forget this. This is a powerful operation. I mean, it has sustained weight loss, but it's because of its power. That it can be suggested to any patient. The patient has to understand the kind of operation he has. It has to avoid certain things. It has to do an extreme follow-up. We feel more secure doing a sleep and losing the patient for follow-up than with this surgery. But obesity is a chronic disease, and we are trying to give most of the results to these chronic patients. And the follow-up team is very important. This is not just the surgeon. I think it's more important than us. I think the main advantage of this surgery is that if I compare it with other surgeries, the most easily reversible one for adolescents. So if we ever had any trouble with malnutrition and this kind of patients, we need to reverse the surgery.
So I want to thank you again, for joining us in the Journal Club. And our Journal Club next month in June is going to look at a very important study that looked at the incidence of post-operative pain after Roux-en-Y gastric bypass in a very large cohort from Europe, showing that at least 10% of patients have chronic abdominal pain.
Yes.
So, we will post the information on our Facebook group and our Twitter account. Again, thank you very much, and have a great day, Dr. Antosi. Thank you.
Thank you, Dr. Nimeri, and all of you.